Good morning. I'll be presenting on behalf of Medicine One. We are presenting a 45-year-old lady who came from Vellore, who had presented with complaints of skin rashes since the last 3 months. They began first on the lower limbs as palpable reddish pinpoint non-pruritic rashes, non-blanching. Initially started from the lower limbs, the thighs and the gluteal region, and then progressed to involve the shoulders and the upper limbs as well. She had generalized pain abdomen since the last 10 days, and she had developed vomiting since the last 10 days, which were multiple episodes, non-bloodstained and non-bilious. She also had loose stools, small volume, no blood or mucus, 4 to 5 episodes per day over the last 10 days. There was no history of fever or black colored stools. There was no history of oliguria or hematuria. There was no history of joint pains or alopecia or photosensitivity or Raynaud's or Zika symptoms. No history of paresthesias and no prior history of upper respiratory tract infections. So she had a loss of weight which she was unable to quantify, especially after her GI manifestation started. She had loss of appetite. There was no significant family history. There was no history of malignancies. There was no past history. Now on examination, she had a pulse rate of 84 beats per minute. Her blood pressure was 120 by 70 millimeters of mercury. Her respiratory rate was normal. She was afebrile. She was pale and she had a predominantly lower limb rash, which was a palpable purpura measuring up to 5 millimeters, which was non-pruritic. However, she had no icterus, no palpable lymph nodes, no pedal edema. Now, this was the rash she presented with, predominantly 4 to 5 millimeters, predominantly over the lower limbs, palpable purpura with no evidence of pedal edema and non-pruritic in nature. On examination, her CNS examination was largely normal. Her deep tendon reflexes were preserved. There was no evidence of peripheral neuropathy. Rest of the systemic examination, cardiovascular and respiratory system was normal. On abdomen examination, she had a diffuse tenderness present, but there was no guarding or rigidity or no free fluid. So in this 45-year-old lady who had come largely with presented with this rash, palpable purpura predominantly over the lower limb, over the last 10 days had developed some GI symptoms, no evidence of malignancy, no associated connective tissue disorders, no history of drug intake or respiratory infections prior. Now, clinically, what we considered was largely a vasculitis syndrome, and small vessel vasculitis was what we considered. Among these, Henoch-Schönlein purpura we considered. However, the age group was not very typical. HSP is largely a disease of children. And HSP in adults, GI involvement is rare. GI involvement is more seen when it occurs in children. Renal involvement, this patient did not have any manifestations, but the predominant lower limb involvement of the rash and with the clinical GI symptoms put HSP vasculitis in our thought process. We also considered ANCA-associated vasculitis like granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis. We considered polyarthritis nodosa as well. But this is largely a disease which affects the arteries, wherein patients classically can have a mononeuritis multiplex picture. Along with, again, there can be GI involvement, renal involvement in the form of hematuria, glomerulonephritis, which our patient did not have. We considered cutaneous leukocytoclastic vasculitis as well. However, there was no history of a drug intake prior, no history of inciting maybe an upper respiratory tract infection. There was so it was not only manifested as cutaneous, she did have systemic symptoms as well. Essential cryoglobulinemia could have been considered. However, this patient, there was no history suggestive of a hepatitis infection in the past, and GI involvement in cryoglobulinemia is rare. And it's usually seen in association with lymphoproliferative disorders, which our patient did not clinically and lab-wise also have. On investigation, the patient had a mild anemia. It was a microcytic hypochromic type of anemia. She had raised counts of 19,700. Her electrolytes were normal. Her urine and liver function tests were normal. Her routine urine examination showed the presence of 10 RBCs, but they were all isomorphic. Her urine albumin was negative. her complements were normal, her ANCAs were normal, her hepatitis B and hepatitis C was negative, rapid BBVS was negative, ANA was negative. Since we were considering a vasculitis, HSP vasculitis also, her serum IgA levels were, however, within the normal range. Now we went ahead with the skin biopsy from the palpable purpura, and this showed the presence of perivascular and transmural infiltrates, mainly neutrophils with lymphocytes and histiocytes with a predominant fibrinoid necrosis. However, immunofluorescence from here showed a predominant C3 pattern, IgA, IgG were negative. So our patient clinically did not have a history of a melena. However, her stool local blood was positive and she appeared pale. Upper GI endoscopy showed patchy erosions, biopsy of which showed a chronic active duodenitis, but there was no evidence of vasculitis in the form of ulcers or any other complications like intussusception. Colonoscopy showed ileocecal valve erythema, biopsy of which again was showed a chronic ileitis, but segmental biopsies were normal. So in our patient, so the histopathology was suggestive of a leukocytoclastic vasculitis, for which we again had to consider what were the differentials that we could think of. Now it's largely idiopathic in 50% of the cases. It can be seen in association with systemic autoimmune diseases. It can have an association with HSP, cryoglobulemic vasculitis, rheumatoid arthritis, hypocomplementemic urticarial vasculitis. It can be seen post-infections, but our patient did not have any history of prior upper respiratory tract infections, was negative for hepatitis B and hepatitis C, no history of drug intake in the past, and no history or investigation suggestive of malignancy. Now these are all immune-mediated processes wherein there is an immune complexes deposited in the vessel wall. Now the permeability of this vessel wall is already increased. Now there is activation of complements like C5a, which are chemotactic for neutrophils. So neutrophils infiltrate the vessel wall and they phagocytose the immune complexes, and this is what leads to the vessel wall damage. So clinical features, now cutaneous manifestations alone can be seen, and extracutaneous manifestations in leukocytoclastic vasculitis is seen in only 30% of the cases. So according to the EULAR definition, the EULAR as well as the Pediatric Rheumatology Society, the consensus definition, a patient can be classified as having HSP if there is a lower limb predominant palpable purpura plus any one of the following 4 criteria. This is according to the Pediatric Nephrology Journal. Now our patient had the first criteria along with abdominal pain. So actually she satisfied the criteria. Histopathology showed a leukocytoclastic vasculitis, but it was not a predominant IgA deposit. There were no features of arthralgia and there was absolutely no renal involvement. So finally, however, what we considered in our patient was a leukocytoclastic vasculitis, a probable Henoch-Schönlein vasculitis. Now again, it's largely a disease of children seen between the age of 3 to 10 years. When seen in adults, it can be seen up to 30 years. More than that is not very common. It has a more male predominance. Now, the difference between children and adults when they present. So, children have 70% of them can come with GI tract involvement. However, in adults, GI involvement, like in our patient, is rare. Adults usually have skin and joint involvement. They may not have renal involvement at presentation like our patient. However, there can be insidious onset of renal symptoms, so it requires close monitoring. Now, this leukocytoclasis, as seen in the pathogenesis, is due to breakdown of white blood cells and the nuclear material, which is deposited as nuclear dust. And though immunofluorescence is classically described for HSP as IgA deposition, now depending on where the section is taken from, if these proteolytic enzymes have destroyed the IgA in that particular segment, we might not find the typical IgA deposition in that particular section. So we can see in the second picture the characteristic fibrin deposition in the post-capillary venules along with the concomitant mixed neutrophilic and lymphocytic infiltrate. So this is the classical IgA deposition that we see in diffuse immunofluorescence. However, this classical IgA deposition might not always be seen. So a summary of the treatment options. So in mild cases, if there's only cutaneous eruptions, we can manage them with conservative therapy. Systemic glucocorticoids are described if there is severe cutaneous eruption, if there are GI manifestations like severe colicky, abdominal pain, if there is renal involvement, and high-dose pulse steroids have also been recommended if there is rapidly progressive renal disease. Now, according to this particular study, again, this was also published in the Journal of Pediatrics in 2006, which looked at the role of early steroid therapy in HSP. 171 patients were followed up for 6 months. 84 treated with prednisone and 87 received placebo. The endpoints were renal involvement at 1, 3 and 6 months and the healing of extra-renal symptoms like abdominal pain and vomiting. So the arm which had received steroids at 1 mg per kg for 2 weeks, there was a significant reduction in the intensity of abdominal pain and joint pain when compared to the placebo arm. So our patient, after discussion even with amongst ourselves and with rheumatology, we had pulsed her with methylprednisolone at 0.8 mg per kg for 3 days, followed which she was put on tapering doses of steroids. Within about 2 days of the pulse, her cutaneous manifestation showed a drastic improvement. Her GI symptoms had resolved and she was much more comfortable clinically. She's on close follow-up with us for the development of renal manifestations which can be insidious and will require a close monitoring. So our take-home messages here for me, it was to look at leukocytoclastic vasculitis because our patient did not present with a typical IgA deposit or with a typical HSP. So we diagnosed HSP largely clinically and based on our EULAR consensus criteria and based on skin biopsy. Histopathology, though is typically with the deposition of IgA, might not always be seen due to the leukocytoclasis and the proteolytic enzyme destruction. Systemic steroids are indicated in very severe disease and it prevents the development of renal disease and it reduces significantly the GI symptoms. Thank you.
Any questions?
She had disease confined to the skin alone, is that right?
Right. Yes, she had GI manifestations.
And your last sentence was said steroids are for serious disease, but you pulsed her with methylprednisolone, put her on high dose oral prednisolone. What is the indication?
Yes, so steroids indicated for severe disease as well as it can reduce the intensity of GI manifestation like severe abdominal pain and vomiting.
Actually, this patient was admitted previously, was conservatively managed, went home, came back within a week with severe abdominal pain. She couldn't even eat. She was throwing up constantly. So that is when we had a discussion because she was quite ill at that time. And it has been shown that 0.8 milligrams of methylpred could be given. So that's what we gave. She came in for the second time and it was not a typical presentation at all.
Yes, sir.
Second time round, she presented like an acute abdomen, very severe pain, exquisite tenderness, and it was clearly an HSP. At that point, we didn't have much options. The question is whether we should have given her, she couldn't tolerate anything orally, so she needed parenteral steroids. The issue of whether she would have been given hydrocortisone or methylprednisolone. After discussion, we decided to give her a short course of methylprednisolone. Definitely oral glucocorticoids were indicated here because she came with recurrence. There was although the upper GI and lower GI scopies were normal and there was no evidence, clinically, almost certainly she had evidence of mesenteric vasculitis because of the severe pain, local tenderness, the persistent vomiting, and these rapidly resolved after the initiation of steroid therapy. Is there any information on her follow-up? Do you have any? She was discharged?
She was discharged, yes, sir. She had come back once to OPD, and there all her cutaneous lesions had resolved. She had no other GI manifestations. She was able to tolerate well orally. She was continuing on her tapering doses of steroids as she had come.
The learning points in this case is the syndromic diagnosis. And the second is that not all patients settle down based on conservative management. Here, actually, when she got admitted the first time, the lesions had settled down. And then, so she was managed conservatively, although she had a history of abdominal pain. So there was no clear-cut evidence of systemic involvement. But she came back within a couple of weeks, right?
Yes,
in a
sir.
week she came back with very severe symptoms, which is why we initiated glucocorticoid.
There are no other questions. We come to the Prithvi has a question.
And there was no history of fever. No.
I'd like to thank all the presenters today for the cases that they presented. It was informative for everyone involved. Thank you, and we will see you next week.